Good morning once again, and first of all, let me thank AIOS and the scientific committee for having us as part of this session. So I'll be talking about common patterns of infective retinitis and how you can use these clinical clues to arrive at a diagnosis without resorting to too many lab investigations, and how we can train ourselves clinically to look at these diseases. Now, the first point, I know this may sound a bit rudimentary, but first thing that we have to do when we come into the habit of recognizing these patterns is to differentiate between the lesion. Are we dealing with a retinitis or a choroidal involvement? And while both of them can overlap, what we need to remember is that usually retinitis lesions are more superficial and they end up obscuring the vessel. So if you see a lesion which is slightly superficial and is obscuring the underlying blood vessel, then you're talking more in terms of a retinitis, whereas choroidal lesions obviously will tend to be slightly more deeper, and you can see a vessel coursing over the lesion. So these are lesions which are emanating from the choroid, will be lifting the things up, and you can see a vessel which will be passing over the lesion. So if you can identify the vessels coursing over the lesion, then it's predominantly a choroiditis lesion. Otherwise, if the lesion obscures the underlying blood vessel, then you're dealing with a predominantly retinitis lesion. So like if you see this, again you see a scar and you see a lesion over here which is obscuring the underlying vessels. So obviously a retinitis, whereas if you see this lesion over here, you can see a deeper lesion with vessels coursing over it. So that's a lesion which is emanating from the choroid and therefore a choroidal lesion. Now moving on to some of the common patterns of the diseases that we can see and how you can use these signs to identify clinical disease. So if you see a patient where you see this synechia over here, granulomatous capes, but more importantly, if you see the subvascular pigmentation, that in itself is a very significant clue to the possibility of TB being an underlying etiology. So a subvascular pigmentation along with vasculitis, think of TB as one of your differentials. A retinitis overlying a blood vessel, again a clue to a possible tubercular etiology. So if you see a retinitis overlying an underlying blood vessel, again that's a clue to the fact that you are dealing with a TB retinitis. Serpiginous-like choroiditis, a very common pattern which we have come to learn a lot about, and we will be talking about this in the subsequent slides, so I will skip upon that. But if you see lesions over here not involving the disc area and you can see pigment clumping over here, think of serpiginous-like choroiditis as one of your differentials, and again that points to an underlying TB as a cause. Moving on to some other common lesions, toxoplasma. Toxoplasma is one of the most common causes of unifocal retinitis. So if you see a unifocal retinitis, can happen in immunocompetent as well as immunocompromised hosts. No consistent direction of spread, can be occasionally associated with a very significant response. So if you see a very significant dense vitritis with an underlying single solitary lesion which you can appreciate through that vitritis, think of toxoplasma. Whereas if you see a significant vitritis but lesions confined to the periphery, that possibly can be a clue to an underlying acute retinal necrosis, and we'll come to that. So retinitis, and remember one of the other significant clues to identifying toxoplasma is the fact that a lot of times you will see it adjacent to a healed scar. So you see a scar and then you see a retinitis lesion adjacent to it, think of toxoplasma. So unifocal retinitis or lesions adjacent to a scar, like what you see over here. So you see this scar over here and then you see a retinitis lesion just adjacent to that. That's a clue to an ocular toxoplasmosis. One more important point to remember is the reactivation. So if you see a reactivation occurring from the center of a scar, that is a clue to tuberculosis. Whereas a reactivation occurring from the edge of a scar usually denotes a toxoplasma. So look at the pattern of reactivation. Moving on to viral retinitis. So CMV retinitis again usually ends up having a classic pattern which we can identify just by a clinical examination. You can see these areas of retinitis, arterial sheathing, multiple hemorrhages. You may have a granular appearance in the periphery. Think of CMV retinitis. The point to remember also is that patients with the CMV retinitis will usually have a very minimal anterior segment reaction, or the inflammation will be very less commensurate to the amount of the retinitis that you are seeing. And the reason for that is that most of these patients are immunosuppressed and therefore do not have the ability to mount a significant immune response. And therefore, while you may see extensive retinitis lesions, you may not see a significant AC or vitreous inflammation, which you may think should be there otherwise. So CMV retinitis has got its own patterns of appearance, dense retinitis with multiple hemorrhages. And another classic pattern can be what is described as a frosted branch angiitis. So absence or minimal vitritis, you can have a fulminant form over here. And remember, the loss of vision in fulminant form of CMV retinitis is usually because of macular involvement, whereas you may have a granular or indolent form, and these patients need to be followed up carefully because they are the ones who will end up having a peripheral necrosis, subsequent breaks, and are more at a risk of a subsequent rhegmatogenous retinal detachment that can happen. So perivascular form, or what is called a frosted branch meningitis, is something which we have already talked about. You see this extensive perivascular infiltration. And this is what you may see in a patient with a frosted branch meningitis. But what we also need to remember is that frosted branch meningitis, apart from HIV or seropositive patients, can also be idiopathic sometimes, can also be associated with Behçet's, sarcoidosis, lymphomas, leukemias, and occasionally SLE. Moving on to one more disease which we are seeing an increased resurgence and which is also very easy to identify if you get into the habit of appreciating these clinical clues, is ocular syphilis. So if you see a ground glass retinitis with a central clearing, think of syphilis. If you see these multiple small mealy lesions, again that's a clue to ocular syphilis. And what has been classically described as an acute syphilitic placoid chororetinitis. So you see a retinitis lesion at the posterior pole with more intense infiltration at the margins or at the edge of lesion. Think of ocular syphilis as one of your differentials. So if you do an OCT through that placoid chororetinitis lesion, what you will find is this RP nodularity, and that RP nodularity and photoreceptor damage again can be a classical clue to an underlying ocular syphilis. And if you do an OCT through these miliary lesions, you can see this full thickness retinitis. So miliary lesions with a full thickness retinitis, ground glass retinitis, placoid chororetinitis with RP nodularity, all of those are clues to the fact that you are possibly dealing with an ocular syphilis. And a point to remember is that ideally we should be getting a tryponymal test like TPH or FTABS done for these patients to identify them, as compared to a VDRL. A lot of times we end up just getting a VDRL done and then we forget to look at TPHA. But the point is that tryponymal tests have got a sensitivity and specificity of more than 90% for syphilis, as compared to non-tryponymal tests which may only have a sensitivity of around 70 to 75%. So this is what I was talking about, the pattern recognition in ocular syphilis. A placoid chororetinitis with intense infiltration at the margins, ground glass retinitis with a central clearing, and these multiple miliary lesions. And another point to remember is that a lot of times these miliary lesions will appear in eyes which have been earlier erroneously treated only with systemic or local steroids. So if you treat an infective retinitis patient without the cover of an appropriate antimicrobial, that's inviting disaster. So if you have treated a patient only with steroids without an appropriate antimicrobial cover, which in this case for syphilis happens to be penicillin, then you may end up seeing these miliary lesions subsequently. So this is one more case which so classically highlights the importance of pattern recognition. So this was a patient seen elsewhere, thought of initially as intermediate uveitis, was given steroids, the patient did not respond. Subsequently started on immunosuppression, still the patient vision kept on going down. Finally, after even IVMP was given, and then at the last resort, the treating physicians gave the patient Ozurex, and you can see these two Ozurex implants. But then when the patient came to our clinic, what we saw along with these areas of hemorrhages were these multiple small miliary lesions. And the moment we saw them, we thought, are we dealing with syphilis? We got the patient tested for HIV as well as TPHA. The patient came positive for both. He was seropositive as well as positive for syphilis. This was a boy who happened to be a recreational drug abuser. But the point over here is that how classically can these clinical clues help us in identifying these diseases. So if you see this multiple miliary lesions, then think of ocular syphilis as one of our differentials. I'll just take one more minute if I can be allowed. Thank you so much. So acute retinal necrosis, another common clinical pattern. You see this extensive confluent peripheral retinitis. That is a clue to an acute retinal necrosis. In patients who are systemically, severely immunosuppressed, if you see this mud crack sort of an appearance with retinitis and occasional perivascular sparing, that's a clue to a progressive outer retinal necrosis, which happens in significantly immunosuppressed individuals. Just one last point about endogenous endophthalmitis and how you can use that also as a clinical clue. So if you see a retinitis or lesion over here, and if you do an OCT, this was a very nice paper which showed how OCT can help us in identifying the underlying etiology. So you see a lesion emanating over here from the subretinal area, protruding into the vitreous with this classic sun cloud sort of a sign described in OCT. That is a clue to a candidal involvement. Aspergillosis, on the other hand, tends to be more diffuse and more subretinal. So I will sum it up now and remove the rest of the slides, but these are the main points. And the main thing to remember is that a lot of these infective retinitis can be identified just on the basis of important clinical clues, and you do not may possibly need to resort to too many lab investigations. All we need to do is keep our minds open, do a good meticulous indirect and a retinal evaluation in most of these cases. Thank you so much.